My name is Dr. Javier Villasuso. Nice to meet you. I'm here taking care of patient Joey Pugh, and he's here because he has back pain and he has referred leg pain, and he has a history of degenerative disc disease. Also, he's had surgery in his back with a fusion. The patient's been suffering with this since 2008, and what I wanted to do was kind of just explain more or less what we do here so that you can get an idea of what we can offer you as far as pain control, and not only pain control but also regenerative potential in the spine. The spine is made up of multiple components, and basically, if we're to look at a model here, just for the impression, you can see that if I were to take a piece of the spine here, the spine has the cervical, thoracic, and lumbar spine. If I were to take a piece of the spine, you can see that there's a disc here in the center. Okay, in the middle there's the spinal cord. At each side there's the spinal nerves. The disc is composed of this annulus part here, which is kind of like this cartilaginous ring. Okay, and in the center you have this jelly-looking substance, which is called the nucleus of the disc. And this anatomy is kind of important for people to understand because this can lead to problems in the future. If the integrity of the disc is compromised, things can get out of control, and most of the time that's usually the case. So what I want to do is educate more than anything, just to let people know about this, because I think the more you understand, the better you will be able to help yourself for the future, regardless of what you do. Education is always number one. So in Joey's case, he had pain that started in 2008, and initially was treated as back spasms. He underwent an MRI, and they found that he did have degenerative disc disease. He came over to the States, was treated by Dr. Alan George in 2011, and underwent a pretty significant surgery. And I'm going to pull it up right here, which showed that he had a laminectomy at L5S1, meaning, and when we say laminectomy, what we mean is the spine is made up of bone. You can see there's a ton of bone here, and there's spinal nerves that come out at each level. This is the lumbar spine. This is L5S1, L45, L34, meaning L5S1 meaning that this is the L5 vertebral body, this is the S1, the sacrum, and this is the nerve L5S1, and these are the discs here in between. The discs, what they do is they act like shock absorbers. So if those shock absorbers aren't working and you're doing a lot of heavy lifting, it'll end up suffering, and that can potentially cause the nerve to be pinched. So what happened was that Joey had this surgery. He had quite a large surgery. He had a left-sided foraminotomy. He had a laminectomy at L5S1. He had an arthrodesis at L45 and L5S1, meaning that they actually put material there to help support the joint. And he also had a fusion, and he had some instrumentation removed as well as placed. If we look at Joey's MRI now and his symptoms, they do correspond. He has pain that goes down his right leg. It's pain that comes and goes, and pain like this that results from the disc rupturing and the nerve being pinched off can manifest in multiple ways. It can manifest as back spasm. It can manifest as pain in the buttocks that goes down the leg into the knee, sometimes into the foot. It can manifest as pain over the front of the leg. It can just manifest as back pain. A lot of people go through this process and they don't realize that the reason that they have that type of pain and spasm is because we need to go to the root of the problem, and the root of the problem is really the nerve. And the nerve has multiple areas in which it can be compromised, being the disc, as you can see here, the disc, the facets, which are in the back, and then there's the nerve. So we need to make sure that the integrity of the disc is maintained, and many times that's usually the case, is that it's not maintained, that the disc begins to soften, this ruptures, resulting in something that looks like this, and then you have the facets, which start to bear more weight. Once the facets start to bear more weight, as you can see here in this example, if we were to connect it to, this is a sample here, the facets, these blue shades here, will start to bear more weight as well, and you'll have arthritis that will form. That arthritis will start to close off and pinch the nerve along with the disc that's bulging out. So you have multiple components that are working together, and it can be a big problem. So what he has taken breakthrough medication, oxycodone, Percocet. He found that this helped him somewhat, but it really did not take away the pain. He has had difficulty with range of motion. He's had pain that shoots down both legs. His right side was worse than his left, and he's even had some weakness down the left leg as well, which many of you who suffer from back pain may notice that your leg gives a little bit, or sometimes when you lay down, you get some cramping. Sometimes you may get a burning, electrical sensation. All of these things are basically your central nervous system telling you that there's a pinched nerve there at that level, and it's pinched because most likely the disc is the number one thing that we see, because that's the shock absorber. That's the one that's bared all the weight of the heavy lifting, the carrying, the pushing, the running. You know, and being part of the military, if you're a military man, you know you do a lot of that. So that's something just to be aware of. So one of the things that we try and do here in the practice, and you know that one of the unique things about our practice is we do a procedure which is called intradiscal ozone chemonucleolysis. And basically, I know that sounds like a loaded word, but what we're doing is we're going into the disc using fluoroscopy, and I'll show you in just a little bit the procedure. You'll see me doing the procedure, and what I do is under fluoroscopy, X-ray. I use X-ray. I can see exactly where I'm going, and I can actually go into the disc with a needle, and I do this all under sedation, so no one is really feeling any discomfort while this is going on. And the idea is just to inject a little bit of the ozone gas. Now, why do we use ozone? Ozone is O3. It's what you find in the atmosphere. It's an unstable molecule. So ozone is actually an oxidant. It's something that when the body feels it or senses it, that it's around, the body's antioxidant properties all of a sudden begin to work. The cells become alive and they attack. They attack whatever is degenerative or whatever is going on. It actually stimulates the stem cells. And at the same time, it binds to the hydrogen bonds, which is the water here in the disc. So it actually causes the disc to go retract back, which is very important. Because as you can see, there's a mechanical obstruction to the level of the nerve. So the idea is, with this procedure, going into the disc, we inject the ozone gas, and this jelly-like substance comes back. You can actually seal off the annulus, this cartilage portion, so that it looks something more like this, again, or like this, okay? So that's important. That concept is very important. I am going to show some MRIs to you in another clip on the first patient that had this done, which was my father. He is the founder of the practice. We've been doing this here for almost 10 years. This is 2014. We started doing it in 2005. He was a patient as well. Back then, he had an L4-5 disc herniation, a very significant disc herniation. And if you could pause it for 1 second, I'm going to try and pull it out so I can show it up.